Okay, there we go. So again, welcome to the second part of the Women of AT&T's National Initiative Fight Against Drug Epidemic, and we're focusing on addiction. This particular initiative, we're going to be talking to Dr. Lyn O'Connell, and let's talk about addiction. Okay, Dr. O'Connell is an Associate Director of the Division of Addiction Sciences for Marshall Health and an Assistant Professor in the Department of Family and Community Health at Marshall University, Joan C. Edwards School of Medicine. She helps advise, implement, and grow Marshall Health's community-based services related to addiction care, treatment, and its underlying causes. Before joining Marshall Health in 2018, Dr. O'Connell served as the clinic director of the Marshall University Screening, Brief Intervention and Referral to Treatment, SBIRT program. In addition to 9 years of clinical experience, she has authored and co-authored numerous publications, presentations, and grants. Dr. O'Connell holds a Master's of Arts in Marriage and Family Therapy from the University of Connecticut and earned her PhD in Marriage and Family Therapy from Virginia Tech. She is a licensed marriage and family therapist. Today we're going to be asking her some very intricate questions about addiction. Some facts that you guys may not know, that every 12 minutes someone dies from drug misuse. That's 5 that's going to die this call. It's very sad, and on an everyday basis, about 1,300 youth misuse prescription drugs. In 2017, if you didn't know, 47,600 people died of opioid drug overuse in America. And my own past mayor, Megan Berry's son, died in 2017 on July 30th. He was 22 years old. So we're going to hear some very interesting information from Dr. O'Connell, and I look forward to it. She sounds like she's very informed. So the first, someone said they can't see me. Oh, no. So the first question that I'm going to ask Dr. O'Connell is, what is addiction?
Great. Well, thank you, Sheila. Thank you so much for having me today, and also thank you to the women of AT&T and Christy and all the different members. I also just want to thank Lindsay and Cassie, who are here with me on Marshall Health campus and helped get everything set up. So thank you to all of you and all of the participants who have joined us today to talk about this very important topic. So first, it's starting with the basics. What is actually addiction, and what does that mean? So there's 3 criteria for addiction. That is what someone is diagnosed with. And that means, first, that they have a craving for the object, and that can be broad, and we'll talk a little bit more about that. Loss of control over its use, and continued involvement despite adverse consequences. And those are considered the 3 major criteria for having an addiction. That also means that other types of things beyond substances one might have an addiction to. But when we're talking about substances, we actually want to refer to the medical diagnosis, because we're not dealing with a lack of willpower, we're not dealing with a moral failing, but rather we're dealing with a medical diagnosis, and that's called a substance use disorder. And that means that an individual has an addiction to a specific type of substance, and that involves alcohol, tobacco, legal or illicit drugs. So those are the major broad understanding of addiction at this time. So I see that the second question is, what are the specific types of addiction an individual might have? So when we're talking about specific types of addiction, I mentioned briefly that someone might have an alcohol or tobacco addiction. But an individual might also be addicted to an opioid. And that's something that we talk a lot about nationally. I know that you all had the opportunity to hear from our wonderful Chief Jan Rader, someone I work very closely with. And that was couched really around the opioid epidemic. And that means that someone might be addicted to a prescribed substance from a physician that is opioid-based, or they might be addicted to a substance such as heroin that is also opioid-based but is considered an illegal drug or one that's not prescribed but often found on the street. An individual might be addicted to medication that is prescribed from a physician, and it's a continuum. So when we talk about this, we really want to understand the continuum of care. You might have been prescribed a substance by a physician. You might be able to take that for the necessary amount of time as indicated by your physician, and then appropriately come off that or continue it or alter that drug or medication. Unfortunately, some individuals may take a drug or medication and immediately feel new or unwanted effects to that drug or substance, and that might start a thing called dependency. And so that doesn't necessarily mean that an individual is addicted because they're on a regulated medical protocol, but unfortunately that they're showing signs of dependency to that substance and might actually still have to be medically withdrawn or their use of that drug or medication monitored. Unfortunately, then we do have some individuals who might use a substance or have access to it, whether through experimenting or through their physician, and they then might actually start taking that drug in more inappropriate ways at a higher dosage, or move on to other advanced drugs such as street drugs or street opioids such as heroin, methamphetamine, or other types of opioids, including fentanyl. And so that's where it becomes much more risky. When we consider other types of addiction, it's important to remember that this doesn't just relate to substance use. You might be addicted to your cell phone, for example. And that's not exactly as formal a diagnosis, but it means that if you have ever sort of said you have a craving for that object, if you don't have it with you, you've kind of lost control over its use, and continued involvement despite adverse consequences, maybe not noticing a red light or a stop sign, or unfortunately being in a car accident as the result of distracted driving. And so we can see how that use might become more obsessive or compulsive. And that's that second category of addiction, which are impulse control disorders. And those types of things include compulsive stealing, compulsive eating. There is such things such as compulsive gambling or other adverse behaviors that an individual might experience. And then lastly, we do have behavioral addictions, and that might mean that someone is addicted to eating, so that they compulsively eat food when they are no longer hungry, or food that they know that is not good for them, or things that aren't really food to most folks. Unfortunately, you can have behavioral addictions in regards to sex or pornography. Using the computer, internet, video gaming is a more recent and diagnosable behavioral addiction. An individual might actually become addicted to shopping or exercise. And then unfortunately there are some self-harming addictive behaviors such as pain-seeking or cutting behaviors, so self-harm. And so all of those categorize under different types of addiction that someone might be experiencing.
Awesome. Thank you, Dr. O'Connell. Another question that we have is what type of help is available for someone who is addicted? And depending on the addiction, where would they find help?
So there are a variety of types of help available for someone who is struggling with a substance use disorder or addictive behaviors. I'm going to give out the first and the largest possible helpline because I want people to be aware of that, and I believe it'll be something that we can post later. But the most rigorously maintained and controlled helpline is SAMHSA, which is the Substance Abuse and Mental Health Administration of the federal government. And they maintain a national hotline that is 1-800-662-HELP. So 1-800-662-HELP. And that's 4357. That national hotline is a place that individuals can call in 24/7, 365 to identify effective forms of treatment. One of the best places online to find effective forms of treatment is the SAMHSA website, and that would allow you to identify evidence-based and rigorous forms of therapy or interventions, including medication-assisted treatment, suicide-assisted, programs specific to veterans or adolescents. And this also means that you know that you're finding a credible source of intervention. States also may have their own individualized state helpline. So, for example, West Virginia has 1-844-HELP-4-WV, and that's our state hotline that an individual in the state of West Virginia can call. Massachusetts also has a state hotline, and that's 800-327-5050. So it's an easy way to look and see if your state has specific help for an individual with substance use or addiction that you would be able to connect into immediately.
Oh, thank you. And someone has added those websites to our chat line. Thank you very much, Dr. O'Connell, for sharing those. Another question, what are the signs that someone is addicted to something?
The signs of addiction mostly focus around an individual who might be struggling with certain, you might first see certain personality features change. That individual becomes more secretive. They are not being as open about potentially their finances or their people that they are associating with or hanging out with. They might also become more anxious or depressed, and that is because they are not having as much dopamine in the brain, and we can talk a little bit more about that. But you might see them starting to lose control or have more obsessive thoughts or behaviors. They may lose motivation or suddenly have anger outbursts. As we know, those could also describe just a host of things. Those could describe grief. Those could describe a mental illness. Those could describe someone having a bad day. And so it's important not to just say, I see these three things, that must equate to a substance use, but rather register them as red flags and a reason to check in with that individual, especially if it's a loved one. Now, if you're dealing with someone who's currently under the influence, you might be more likely to see enlarged or pinpoint pupils. So your pupils can be very telling of a substance use disorder, along with weight loss or extravagant gain, insomnia, a lack of coordination. And these are all things that we might know that you might witness in someone who's unfortunately using substances and unable to control that use.
Awesome. Do certain disorders cause addiction? Can we see?
Do certain types of personalities cause addiction?
Yes.
No, there is no such thing as an addictive personality, and I think that's an important thing. That is one of those myths out there in the community, that an individual might have an addictive personality, and we just know that that's not true. We do know, unfortunately, that genetics can play a rather significant role in the development of addiction or substance use, but we're not very clear on the genetic influence. And so there's about a 40 to 60% link to an individual's genetic history. Now, that doesn't mean that just because you have a family history of substance use that one is going to engage in substance use in the future, but it does mean you have an increased risk for that. We do know that there are other certain risk factors in personality types when it comes to substance use, and that includes factors that women, unfortunately, who have more signs of anxiety might be more likely to cope with their anxiety through substance use, whereas men who are more likely to be adventurous or risk-taking may be more likely to use substances. Now, that does not create a very black and white incidence in which men experience this and women experience that, but it does mean, again, that those are more likely for someone to start experiencing substance use overall. And then we also know that there are certain mental health disorders that might lead to a greater likelihood of substance use disorder, and those include things like depression or anxiety. We know that more severe mental health disorders, such as schizophrenia, have a strong link with substance use disorders. And so that co-occurring disorder is more likely to occur when a mental health disorder exists. Someone might start coping which makes the mental control, and unfortunately creates a sort of evolving and revolving door around substance use and a lack of ability to control or understand their mental illness.
Oh, is there anything that people can do to prevent addiction?
Unfortunately, no. Addiction is not something that an individual can actually prevent overwhelmingly. We can do certain things, though, as a community to prevent addiction. We can reduce exposure, especially early exposure to a substance, and this involves educating our students, especially at a young age. So here in Cabell County, for example, we know that our local statistics from our harm reduction program indicate that adolescents may start using substances before the age of 10. And this factor would mean that if we are waiting to provide a drug education program in high school, we are way too late in that intervention and that service being provided. So we want to make sure that kids have access to substance use disorder knowledge and treatment very early on. And so that means an evidence-based, comprehensive education program in the schools. And there's different types of programs like that, including Too Good for Drugs and community prevention coalitions that help an individual engage or provide some education in regards to treatment. We also know that the best thing that we can do to prevent substance use is to help someone treat their self-esteem and to promote factors of resiliency. So when we're talking about resiliency, it means that an individual has greater self-esteem, has better ability to cope, knows more factors about health or well-being, has access to positive supports, and has a reduced experience of trauma. And so those factors are all things that might help someone, unfortunately, down the pathway to substance use if they're not strong and we're not creating resilient youth. Once it becomes with adults, one of the most important things we can do is promote screening and early interventions in our communities. And that means that when you're talking to your doctor or a healthcare provider, that you're open and honest about your substance use concerns. And they're then able to provide some early interventions. Maybe that's education, maybe that's talking about risk factors, or maybe that is providing more comprehensive treatment, whether that be at the community level, the family level, or actually residential forms of treatment.
Yes, hi, I have a question.
Hi, can you ask the question in the chat? I'm so sorry. The question that I had was, can you go over the treatment options like detox, rehab, and therapy?
Yes, absolutely. So, yes, detox is not a treatment, and I think it's very important that we make that clear. Detox is a medicated withdrawal, and the way that we're actually moving towards that term in the treatment community is to say that detox is withdrawal management. That's all it's doing. It's the same thing as going to your doctor and receiving one dose of asthma medication and never going back again. One dose of insulin and thinking your diabetes has been managed. Detox is purely something to make sure that someone does not die as a result of withdrawing off of a substance. Drugs like benzodiazepines and alcohol can kill you. Or if someone was pregnant or had other pre-existing conditions, withdrawing off those substances can be deadly. And so it's important that an individual has access to withdrawal management that then funnels them into a formalized treatment. So withdrawal or detox by itself, unfortunately, can lead to increased rates of fatal overdoses because the body goes through such a shock in their detox, they are not able to access, when they go back out to the community, they don't necessarily have any resources or education to help actually treat their disease of addiction. And so unfortunately, they end up using substances and the body has gone through such a shock that they're more likely to fatally overdose. And so it's very important that detox, if it's a part of the process, is step 0.01 that leads to step 1, and that would be a formalized version of treatment. Now, treatment can include a host of things. It could include community supports like AA or NA, those are 12-step programs. It could include family supports like Al-Anon or codependency groups, the loved ones group, celebrating family, celebrating recovery. Most of those are national programs that both an individual who's using substances and or their family can access. Other types of treatment would then include individual or group therapy on an outpatient basis. An outpatient means that you go there, you might go there for an hour a day or an hour a week or an hour a month. You receive that therapy and you go back home to your own community. More intensive, called intensive outpatient treatment, means that you actually go there for a good chunk of your day every day, but you're not living on site. And then the third form is that intensive level of care, and that's going to be residential treatment, and that is obviously very different than outpatient because you choose to move out of your home and you move into a residential treatment provider that may provide services for 4 to 6 months, 6 months to a year, rarely longer than that, but that sort of average length of stay for about 6 months to a year is considered average for a residential treatment program.
Well, thanks for that. Well, we have plenty of questions coming through our chat, and if anyone has a question, definitely please put that in the chat, and we will answer as many questions as we can in our session today with Dr. O'Connell. But the next question is, what does recovery look like?
Well, thank you. That's a great question. It's the other side of the coin that we get to talk about. Now, the difficult thing about that question is it depends. It is absolutely a subjective conversation because, unfortunately, for each individual, their pathway to recovery is different. And what it looks like often for us is extending the time between use, reducing the risk of use, and promoting healthy behaviors while using, if possible, right? So those might not sound like great definitions of recovery, but if your goal is to keep that individual alive, because that is someone's mother, daughter, sister, brother, cousin, uncle, it doesn't matter. That's someone who unfortunately is using substances, and our goal is to keep them alive, to engage them in long-term recovery, because we know that that is possible. And so recovery might mean that we are taking it one day at a time, and that is often something someone might say. But what we want to do is encourage that each individual defines their own, what does it mean to be in long-term recovery? We know that what we might need to do is increase decrease the type of drug they're using, right? Can we cut back on the use? Can we decrease the amount being used? Can we decrease the frequency? And can we make sure that you're engaging in less risk-taking behaviors? And that might mean that you're not using alone. That might be engaging in a harm reduction program to maintain greater use self-care. It might mean engaging with a physician to make sure that you're being tested for infectious diseases or other types of risk factors. But what we want to do is make sure that we're promoting all pathways to recovery for each individual. And so what they look like at the end of that is going to be different. I've met folks who are a year in recovery and they say, I'm in long-term recovery, and other folks who don't want to say that for a while. It means something different to them. Other individuals might say, today I'm in recovery and that's all I can count for. And so what it means is that that individual has a process that they are currently working, whatever that means for them, and that they're promoting self-care and wellness in their life, and often that they have the support of others to make sure that they're being honest and confronting those red flags in their own life.
I have a comment for your response. Someone says that they have been told that long-term recovery is something that people have to work on every day forever to prevent relapse and take day by day. What is the best support that someone who is recovering from substance dependency and addiction, what is the best recovery for that person?
Again, that's really going to be personal, but yes, that idea of working recovery every day of your life is important. I think it's the same of any habit you might have tried to change in your life. And substance use is a brain dependency, and hopefully I'll address that in a moment. But when we talk about other types of behavior that we want to change in our life, I won't poll the audience and make you all out yourselves, but how many of you are still maintaining your New Year's resolution, right? It's only March, right? It's only March, guys. We're 3 months in. So I assume all of you made a decision on January 1st, whatever it was, and you've stuck to it. No, right? Being realistic, I talked to people on January 3rd, and they'd already given up. I just don't make them. That's how I get out of failing on my New Year's resolutions. But when we talk about making a change, it's very easy for you to say, I'm going to drink water today, and you do. You drink enough water, you get up out of your chair, you make sure when your Apple Watch tells you to breathe, you breathe. All those little functions that we set up in our lives to remind ourselves, just like we do that to ourselves, is the same thing as someone working a process of recovery. I don't need to eat this right now. I don't need that substance to feel better. I need to have other healthy activities in my life. And so the biggest thing is not just giving up something, but then making sure you're supplementing other things in your life, like healthy relationships, making sure that you might have exercise, right? Because when we talk about a brain disease, we want to ensure that we're actively activating our neurotransmitters in a new way, not just in the way that substances provided. We want to make sure that we're engaging in just overall health and wellness, and that it can include healthy eating, making sure you're getting all those other factors that are going to help an individual maintain that life of recovery every day.
Well, thank you for that. And I can see that our audience is fully engaged in asking quite a bit of questions of you. Another question, what are the relapse stats?
So what we want to talk about when we talk about addiction, I'm just briefly going to mention sort of the understanding of the brain when it comes to addiction. So what is the brain doing when it comes? Because that's how we understand what does relapse mean. So a substance use disorder, whether it's the first time someone uses a substance and it's prescribed, or they chose to experiment with a substance, either one, what actually occurs is that the brain is flooded with dopamine. Dopamine is a neurotransmitter, and our dopamine neurotransmitters that respond and are activated are deep inside the brain, and they're actually in what we consider the pleasure center of the brain. And so we have 5 neurotransmitters overall, but dopamine is the one that is most activated by the initiation of a substance. Dopamine is also very active in other types of diseases. So Parkinson's is associated with the loss of dopamine in the system. Schizophrenia is associated with overwhelming amounts of dopamine in the system. And so we can see that it can play this integral role in brain development and muscle control and regulation and emotional well-being. So dopamine is very important in our body. And what happens when someone takes a substance is that they have a flood of dopamine. For some of us, that might not do too much. We might be able to take a substance, have that flood of dopamine, but it's okay. We go back to producing our natural dopamine in our body that we had every day. Other folks, upon first ingestion of that drug, might have flood of dopamine and suddenly feel normal, suddenly feel whole. And that means that they might have had lower levels of dopamine, or they had other risk factors for why, and they might start seeking that level of dopamine that is normal for other people in the population. And so that is what we see when we see substance use disorders. We actually stop using dopamine because it's reliant on that outside external dopamine, the drug, and so that over time that thrill and rush are naturally supplemented by that external force, and the brain isn't doing it itself. And that's why we consider addiction a brain disease. A substance use disorder is a chronic relapsing brain disease at its most formal level. We know that dopamine is also affected by stress, but unfortunately sometimes stress can give, or dopamine doesn't actually say, was that a good dopamine or a bad dopamine? It just says, I had a rush of dopamine. And so it can label both positive and negative events in a same dopamine stimulating way. And so when we see that, we unfortunately know that that is what is the underlying cause in many cases of substance use disorder. That's also why it's linked to impulse control and other factors. So when we consider it as a chronic relapsing brain disease, we look at other chronic diseases out there, and that includes things, the sort of top in the United States include hypertension and asthma as chronic relapsing diseases. And that means that of people with those conditions, about 40 to 60% of them stop taking or following their medication protocol and have a relapse of their condition. So when we talk about substance use disorder, it's about a 40 to 60% relapse rate. When you talk about something like asthma, it's a 50 to 70% chronic relapse rate. When we talk about high blood pressure or hypertension, it again is about a 50 to 70% relapse rate. And so that means that substance use disorder actually falls just below those in chronic relapsing conditions. When we're talking about accessing recovery, we unfortunately know that it takes someone about 6 or 7 times, really the research around this is in regards to opioids, but 6 or 7 times to effectively engage in long-term recovery. And again, we're talking about an average there, which means some people walk into a recovery center or meeting and never look back and enter a life of long-term recovery, while other individuals might be on their 6th or 7th or 12th attempt at recovery.
I'm still here. Okay. So the last question that was pre-submitted was, what are the most common reasons for relapse? But then we have quite a bit of questions on the web that I would like to ask you as well. But this is the last pre-question that we have. What are the most common reasons for relapse?
So the most common reasons for relapse include stress, not treating mental illness. So if we know that mental illness and substance use disorder have about a 50% correlation rate, if someone stops treating their anxiety, their major depressive disorders, their post-traumatic stress, then unfortunately we know that they may be more likely to continue to use other self-soothing or self-medicating things to cause that relaxation. And that might be substances, that might be unhealthy sexual relationships, that might be gambling or other thrill-seeking behavior. We also know, unfortunately, that lying, both to oneself and to one's loved ones, can be both a risk factor and a red flag for relapse. And that's because as we are all humans, we want self-protection. We want to tell people that we are okay and thriving and alive. And that means that we often might mislead ourselves or others in our life so that they are unaware of those other factors. We also know that that having negative people, places, or things, that's something that's very commonly said in 12-step supports. You got to change your people, places, and things if you want to change yourself. And so re-engaging with people or places or things that led to your addiction might also lead to unhealthy behaviors in one's life. And lastly, something I always try and remind people about is that anniversaries or hard times of year can be a trigger for relapse, right? We might have a bad day in our life and sort of then realize, oh, today's the anniversary of blank. Today's the day that a loved one was diagnosed or died from an illness. And so you just automatically feel in that funk. And if you don't prepare for that funk, you might look to go back to things that made you feel automatically better, right? We want to feel better in our life. And so if we look back to things that will make us automatically feel better, then we're more likely to engage in those and turn away from our program of recovery.
Well, thank you very much, Dr. O'Connell. The first one from the web is, kids think pop isn't addictive. Some are vaping THC or TCH, which was higher concentrated. Is this addictive, and what are the dangers?
Thank you. That's a great question and absolutely a hot topic. I want to just mention one thing that is everything that I discussed today I can cite. I can go and find you the peer-reviewed article in regards to it. One of the biggest problems when it comes to marijuana, THC and vaping is the overwhelming lack of empirical and peer-reviewed research on this topic. And there's a lot of factors as to why that is. But it's important that we identify what we know and what we don't know when it comes to a substance. When we know, there's a lot of things going around right now that vaping is not dangerous. There is some initial research out, and today I was actually reviewing that with some folks, that the initial research around vaping is that it actually might be far more damaging for adolescents to engage in vaping behavior because of the flavors have actually been linked with nicotine, but now especially similarly in vaping, have been linked to changes in the brain and changes in brain structure. And while an adolescent is still developing, we know that early engagement with any type of substance is very risky because the brain is not fully developed. And so we don't want to do things that alter its long-term, right? We don't want to have trauma or abuse or neglect or substances enter what is a forming and growing structure. And so we know that earlier use of any substance is associated with increased rate of both dependency and or addiction in the future. And so when we talk about marijuana, one of the largest problems is that marijuana has changed over time. The way that it is produced, the levels, and the amount of the different types of substances within it have changed. And so it's not necessarily a lot of the research on this it will say it's not the pot of the 60s. And so that the type of chemical within that substance has changed. And so we don't know. We don't know what such high levels of THC can do. But when it comes to adolescents, just because something grows in the ground, poppies grow in the ground, they create heroin. Heroin is the opioid epidemic that we're dealing with right now. Lots of things that we can have or ingest in both large quantities or at not the appropriate stage in our life are not a good idea. And so it's talking about that brain development, talking about promoting other coping factors. If you're smoking because of anxiety, we need to treat that anxiety because you're setting up for a longer pathway of risk and unfortunately a potential higher risk factor of substance use.
Thank you again for that. The next question is, what about when you have a child who is over 18 and addicted to opioids? Parents have no rights. The rehabilitation facilities will indicate that the person must directly call to set up their acceptance to the facility. The problem is you are dealing with a person who is on drugs and they are not going to do it. What can a parent do to help them?
That's a great question, and one, unfortunately, that I confront almost daily. There are some, what we often encourage for that family member is to engage in, there are some curriculum and training and or support groups for the loved ones of an individual with a substance use disorder. One of those is most simply called the Loved Ones Group. And that is a support group for family members of an individual who is currently struggling with substance use disorder and or addiction. There are other groups called the CRAFT, and that's an acronym, CRAFT, and that helps families engage in motivational interviewing, which is to help an individual identify the factors that would make them more motivated to engage in treatment or recovery. Those both can help the individual or the family member try and motivate that individual with a substance use disorder towards treatment or recovery. Unfortunately, the other factors are that an individual is likely not to enter recovery successfully until they are self-motivated, until they decide to engage in it. And so in the meantime, we want to make sure that family members and loved ones have support, whether that's individual or couple therapy for themselves and or their partner if it's a child of theirs who is struggling. We want to make sure that we try and really activate our community here and our faith community here, because something that we know that has occurred is that the community doesn't turn around and support someone in the same way. So, in Appalachia, it's really important, it's like someone ends up sick and it's casseroles coming out the ears. The whole community shows up. We're there to support or engage that individual. But when it comes to substance use, we don't do that. We stigmatize people. We don't engage them. We stop asking about it. And so we want to try and find ways to engage our community around that individual or family. And then lastly, we do like to make sure that that individual does know of the available resources. And so here in Huntington, we have things like the quick response team that go out to the scene of an overdose, or a loved one can call, and we will go out and check on that individual. And that just assists us in engaging that individual and family with the available resources. And I would just add that if you're in a community that has Narcan available to you, that you get trained in Narcan administration. It's very simple. In many states, it's available through a prescription or your health department, and Narcan is the opioid reversal drug. I am never without it. I carry it at all times because I never know when I'm going to be in a situation to save a life, and that means that we also want to make sure families have access to that and or individuals.
Please hold 1 second. We're having some technical difficulties. 1 moment, please. Our speaker is coming back. Hello. Okay,
Hello,
sorry about that.
I'm not sure, did you lose most of my response to that question?
No, you were almost finished.
Okay, great, good.
So the next question, we definitely consider you a superhero for all the things you do to help people in crisis. You're an awesome person. But if you had a magic wand, what would you do to end the crisis of opioid addiction?
That is quite a question. To me, I will say one thing that I think would make a significant difference, and I don't think there is a magic pill, unfortunately, for this topic, but I do think if our communities ended the stigma towards an individual with a substance use disorder, we could make a significant difference in this, because we would address it with the appropriate funding, we would have addressed it sooner, and we would put the available resources towards this epidemic that are necessary to change it. And that means that, that means, for example, that when I talk about it, as you've heard throughout today, I say an individual with a substance use disorder. I do not refer to addict, and I don't refer to the word junkie. And I really use person-first language, because that means that we are talking about an individual first and foremost. And so when I talk about it, I always advocate for this. We do a lot of stigma trainings in our community to say that's an individual. When we talk about addicts or junkies, it's a lot easier not to care about them, to say, I hope they die, and those horrible things people write online or say out loud when they think no one else cares. When we're talking about this, that's a person, and I know that there are unfortunately side effects of substance use disorder that are not pleasant for the individual, the family, or the larger community. But if we give it a name and we recognize that those individuals have pathways to recovery, we're more likely to engage with both them and the family. We're more likely to allocate the necessary research and resources and funding, and we're more likely to create that pathway for that person, because stigma is the #1 barrier to accessing treatment. If we control for transportation, insurance, childcare, many other factors, that stigma, that unwillingness to say, I'm one of those people, is what keeps people from accessing treatment. And so we want to move away from that. And so It's not going to be the quick fix, but it is something that would make an actual impact every day if we stopped using stigmatizing language, and we really remember that there's a person in that sentence and a person in that conversation. Now, clinically, I want to promote more family treatment. That's something that we're working on here locally. We've opened a treatment program that allows women to bring their children and be on all different pathways to recovery, whether that be medication-assisted treatment or substance use or abstinence-based programs or faith-based. And so that means that mom doesn't have to make a decision between recovery and parenting, and so we're promoting both at the same time. I would love to see more programs like that, but at the end of the day, our goal is to work ourselves out of a job. I don't want to talk about substance use, but we know that if we don't create the necessary framework and mental health resources to address this, there will be another epidemic right behind it that as a country we are again unprepared for and caught off guard in regards to. And so we want to use this time to build that framework, build those resources, have these important conversations, and make sure that we're ready to engage the larger community.
Thank you for that answer. And I have to control my verbiage as well on that. I would. Can you hear me now? Can you hear me?
Yes.
Okay. So what I was saying is we'll have to control our verbiage on what we say as well. I'll definitely put in my vocabulary not to say addict. Our next question is, if someone was incarcerated, can you tell me what type of treatment do they get and what should they do once they come out of prison?
Okay, I got a few of the questions here from our team locally. So one of them that I heard that has been a topic of interest is what is when an individual has been incarcerated and they are in prison, is there any type of treatment, and when they leave, what type of treatment should be provided? First, I will state that incarceration in the majority of the country involves little to no treatment, and that a large number of individuals can continue to use and maintain substance use disorders while incarcerated. So unfortunately, it is not a place for individuals to receive treatment. We have had fatal overdoses all across this country. Unfortunately as well, when an individual leaves incarceration, they have an 86% likelihood of relapsing and a recurrence of their behavior, and they're at an over 50% increase of a fatal overdose, similar to leaving withdrawal management or detox. And that is because the body has gone through a shock, they've gone through withdrawal, they might have been using relatively diluted or less potent drugs, and so when they come out, they're more likely to use a substance and having an overwhelming reaction to that. They might use the amount they were using before they went in. That might lead to a fatal overdose. They might use with someone they didn't know before or someone who has been advancing their usage, and so again, they increase that likelihood of risk. There are some effective programs in the country that really target those who are incarcerated, and we started one here in Cabell County that's a pilot to introduce medication-assisted treatment, which is continues to be the gold standard of evidence-based treatment for an individual while incarcerated. And so if they receive that treatment, they're in therapy, they're in groups, and they're working that program, they then can exit and step down into drug court. And drug court, or I like to call recovery court, to again put a non-stigmatized spin on it, is a program that allows individuals to meet certain standards and or have their charges brought back against them should they not meet those standards, including urine drug screens, weekly and or daily check-ins with a judge, and other types of ways of holding an individual accountable. And there are both juvenile drug courts and adult drug courts that have been proven to be very successful and can be an excellent resource for an individual. There's other programs such as diversion programs like LEAD, that allow an individual to divert from jail or prison, but again, to meet certain standards of therapy or treatment to prevent that incarceration. And those have been shown to be far more successful or effective as well. Because unfortunately what we know is that once an individual is arrested for drug crimes, they are unlikely to receive treatment. They are now likely to network with not so positive a group of individuals. And when they're released, it's harder for them to find housing, it's harder for them to find stable work, transportation, get their car, pay off those fines. We've really just set an uphill battle for that individual to successfully re-engage in the community.
Okay. If you can hear me, I wanted to state what someone said. They said, thank you very much for having this doctor on. She knows her stuff.
Sheila, I can't hear you, so our team just sent me another question from the group, which is, what do we do when it comes to addiction versus homelessness, and or one and the same? So this is actually something that obviously can become very commingled and very difficult to separate. So we know that we deal with individuals who have addiction, and that substance use disorder might lead them to become homeless, and so they're unable to maintain re-engage in that system in a better way. And so what we know about that is that we want to make sure that we can provide safe and healthy housing for folks when possible, and if not, effective day programs. So we have things such as First Steps or Harmony House, and that means that someone can come in off the streets during the day, engage with a recovery coach, have access to a computer, they can have a workout room, there will be recovery supports, groups, food, a shower, maybe a locker, and then we can start to engage them in programs like rapid housing or other types of recovery programs. And so those mean that we have made that connection more with the individual so they have greater access to engaging in long-term recovery and finding suitable housing. Now, both of those can be a chicken and egg situation. Unfortunately, someone who is homeless might start using substances because of the fact that homelessness can be traumatic and a negative experience for the individual and all that comes with that engagement process overall. And so it can become a very difficult chicken and egg when you're dealing with both homelessness and addiction. But what we want to do is make sure that we continue to provide both the homeless community and individuals with substance use disorder active access to rapid rehousing programs. You need to give me another question.
Okay. Is there an FDA-approved program to withdraw from Adderall?
Yeah, that's really sure.
Okay. How about? Okay. What did we already answer the question? What can we do for a recovered addict?
Yeah.
We did. Okay. What methods do you suggest approaching someone, specifically a loved one who you think might have an addiction?
Sure. So what is an effective approach for talking to someone who you are worried about might have a substance use disorder? First and foremost, the show intervention did us all a disservice by seeming to think that if we gang up on someone and sort of jump in on them, that we're more likely to have success. And unfortunately, we know that's not necessarily true. It is best if one or two people approach that individual, not in a spontaneous or attacking fashion, but rather speak using the quintessential therapy statements of I. I am concerned, and I would like to engage with this and this, or, can you explain these sorts of behaviors or things? Are you worried about this? And so having an honest or healthy conversation is going to be far better than people ganging up on a loved one or individual, because we're not going to see that potential long-term change. It might be far shorter change for someone in that case, because they might feel moved in the moment, but not over time. I work with a great individual who always says, fear gets you into recovery, but it doesn't keep you in recovery. And so fear is not an excellent motivating tactic in the long term. We might use it in the moment, but we really want to make sure that we're displaying empathy and compassion towards that individual rather than anger or fear. And so having a sort of a concrete idea, not necessarily coming in with this planned intervention, the group circle, all of those sorts of factors that we often see on television is going to be far more appropriate. You know your loved one, and so making sure that you approach them in the way that you think is best. You're the expert on that person. You really know them better than anyone else. And so being open and honest, sharing your concerns or what you're willing to do, next steps, how you're willing to support them, and or what you're no longer going to do. I'm no longer going to give you money for gas, because giving you money for gas frees up your other finances for other things, right? A lot of folks may try and do that. They barter. I'll give you money for gas, but I won't give you just cash. Well, if we're giving money for one thing, we are continuing to enable other behaviors. And so having a clear and specific line about what you are and are not going to do is also very important. Because it is unfortunately a product of substance use disorder, is to identify different ways to use, not always nicely, the people in your life to get what you need to get. And people are very creative and resourceful. And so we want to make sure that we reduce that possibility by being clear, definitive, and then sticking with it, even when people unfortunately start to cry or utilize other emotions in a way to manipulate or threaten or bully the situation. So knowing where your clear line in the sand is, seeking your own therapy or support for that can be a great way to do it, so that you know what's within your realm of comfort and ability.
Again, thank you, Dr. O'Connell. We really, really, really appreciate you, and thank you for attending this Let's Talk About Addiction. This is a topic that is truly of interest to our members. We have several questions that people still need answered, so I will get with you in regards to the answer. I want to remind everyone who is on the conference bridge to please document your volunteer hours, because this will be considered volunteer hours for you. Our next final webcast is a series coming up soon, so stay tuned. We have some very interesting stories coming from people who have had issues in the past, and they're going to actually talk about how they recovered from them. Thank you again for listening to our Women of AT&T Let's Talk About Addiction with Dr. Lyn O'Connell. And we will get these questions answered and put on our T-Space again. And you guys have a awesome end of the day. Thank you very much.